Welcome to AETCM's Emergency Medicine channel. Today we'll be discussing a case of acute severe pancreatitis that was presented to our ER. A 24-year-old male presented to our ER with complaints of abdominal pain for 3 to 4 days. Initial 10-second assessment, patient was conscious oriented and was speaking relevantly in full sentences. So we went with the primary survey. Patient's airway was patent. There was no signs of any airway compromise like any pooling of secretion, gurgling sounds, hoarseness of voice, stridor. And patient coming to the breathing part, patient was maintaining a saturation of 96% at room air with respiratory rate of 20 per minute with adequate chest excursions bilaterally, and patient's air entry was bilaterally equal, and there was no added sounds, no crepitations, no wheeze. So coming to circulation part, patient was having a heart rate of 90 beats per minute. It was regular in rhythm, and patient had a blood pressure of 110/60 millimeters of mercury, and there was peripheral pulses were also well felt. Coming to the disability part, patient was having a GCS of 15/15. His DRBS checked was 135 milligram per deciliter, and since he had came with complaints of abdominal pain, we had asked for the pain score. So patient was complaining of a pain score of around 6/10.
So, in the terms of perfusion pressure, two clinical entities are very, very important. One is mental status. See, altered mental status will portray there is some compromise in the oxygenation or the perfusion pressure. Number two, the simple clinical is urine output. So it's mandatory. 3-4 days patient pain. So this also should go along in the history. Okay, don't forget. Okay. Simple thing, urine output is reduced automatically, the perfusion pressure directly represent that. That's why urine output is important. Okay.
So at this time, we had secured IV cannula, and the patient was given injection tramadol 50 mg IV in 100 ml NS, over 30 minutes was given, along with an antiemetic was given, and 6/5, sir.
What are the complications of tramadol? An ER physician should know.
One is MSS, sir. It has vomiting is there. Then seizure potential. It will lower the seizure threshold. Okay. So if patient is prone for seizure, there will be chance of seizure.
Okay. Anything else?
Then coming to exposure part, patient's temperature was checked. He was febrile at the current state, and hypothermia was prevented by providing him blankets. So at this point, after the primary assessment, we have a patient with complaints of abdominal pain for 3 to 4 days duration, having a pain score of 6/10 with no other significant problems in the initial primary assessment. After giving the analgesic, we reassessed him, so the pain score was coming down.
What are the common causes for epigastric pain?
Epigastric pain, it can be simple gastritis, sir. GI causes can be like gastritis, any peptic ulcer, GERD, pancreatitis. Then can be sometimes MI, inferior wall MI. Then can be because of a pneumonia, lower lobe pneumonia. Then can be sometimes aortic aneurysm rupture or dissection. All those things can present. Then other things are from skin to inside, like any small abscesses, any contusions, like trauma, anything can present. We went with the secondary survey and the sample history. So patient, there is no comorbidities. There is no history of any smoking, non-alcoholic. So the patient is having a history of COVID-19 infection in 2020, and he has a history of acute pancreatitis around 1.5 months back. He was symptomatically conservatively managed, and after that he was completely fine. But for the last 3 to 4
common cause of pancreatitis, what are the common causes?
Gallstones, alcohol, and drugs. Some drugs that can be basically this chemotherapy drugs, then azathioprine, all those things. Then antiretroviral, some drugs can cause. Steroids, prolonged use can happen. Then
NSAIDs, NTT,
idiopathic.
Viral fevers. One of the common cause for pancreatitis, which we are not able to pick up, is many viral fevers can mumps, dengue. All these things can present with the minimal pancreatitis, leptospirosis. So infections are one of the most important causes, other than the alcohol and gallstones.
Then other things like the scorpion sting, all those things can cause pancreatitis. This patient had complaints of abdominal pain, that is like initially it was like diffuse pain and radiating to back for around 3 to 4 days, associated with vomiting, and he was hence admitted to a peripheral hospital where he was diagnosed to have acute pancreatitis, where USG was done suggestive of bulky pancreas.
How do you diagnose pancreatitis?
Sir, clinically the symptoms will be there. Then we can go for USG or like imaging modalities, and lab tests are there. If the amylase lipase levels are more than
Will USG pick up pancreatitis?
bulky pancreas.
Bulky pancreas can be there. Most of the time it will be normal. In severe pancreatitis, like you told, bulky can be there.
Then
But all user dependent. If the user is good, then you can pick up.
then amylase lipase levels will be more than 3 times the
Amylase or lipase, which is more specific?
lipase is more specific than amylase.
Okay.
More than 3 times the upper limit of normal, it will be like specific.
Best
more.
investigation?
CT is
CT or
like,
MRI.
but that too maybe like after some 48 or 72 hours if we do, it is more important in picking up the complications like collections and all those things. So this patient, his like USG showed up bulky pancreas, and so he was managed there. But there, like he had complaints of reduced urine output, and was hence referred here. He had also developed yellowish discoloration of sclera, and all those complaints where jaundice was also there, and hence he was referred here. In like there was no history of any fever and no history of any drug intake or anything prior to this event, sir. On examination, patient had icterus, and
When the patient is having associated icterus in pancreatitis, what are the differential diagnosis? Is it simple pancreatitis or
biliary pancreatitis? We have to suspect
obstruction to the biliary tract?
gallstones or anything, CBD tract obstruction.
Okay, then
Head carcinoma.
carcinoma, anything which enlarges the size of the pancreas can obstruct. Okay, whether it is pancreatitis producing large pancreas or biliary this one, or malignancy, all these things.
So
Anything else? Normally, pancreatitis means there is no jaundice. Normally, but some patients can have. Like you told, some associated condition can have.
then hemolysis.
A young child who is not alcoholic, who is not having stones, coming with jaundice with pancreatitis. Male. Which autoimmune infection will affect in this age?
Young child, it will be the
It is viral fever. Most common thing what you are seeing in our practice is a viral fever which produces jaundice, pancreatitis, renal failure. Many viral fevers can have renal failure also, like hantavirus can produce renal failure. But pancreatitis, we have to find out what any other cause is there for recurrent pancreatitis. Okay.
So on examination, patient the icterus was present, and perabdomen was soft, and there was diffuse tenderness, but no rigidity or guarding, and respiratory system air entry was bilaterally equal, and there was no V's or no added sounds.
Common respiratory findings in pancreatitis.
Sir, ARDS can
Okay, ARDS common.
Pleural effusion.
Common is pleural effusion. Always most of the pancreatitis will have
Some pleural
which side pleural effusion? Left side pleural effusion is very common, and ARDS, like told, ARDS can be there.
Then CVS examination was normal, sir, and also CNS there was no altered mentation.
What serious common finding?
Again effusion we
Again
had to,
pericardial effusion is pericarditis. Pericardial effusion is common with pancreatitis.
This patient we went with the other clinical investigations and all. So he had a saturation of 96% in room air.
Hey, you told renal shutdown is there. What is the reason for that? What may be the reason?
One is like hypotension, shock, all these things related with that.
Hypovolemia is due to
Third space for loss.
okay, loss of fluid into third space.
Reduced intake will be there.
Vomiting.
Okay, then
Then associated condition, any like other infection causing.
okay, infection producing both kidney involvement in this.
Then the drugs he might have taken for the pain.
Most
relieving
important
the
thing
pain.
is drugs. Okay, patient may be taking painkillers like NSAIDs.
NSAIDs.
That is one of the common cause for renal shutdown in pancreatitis. Okay, patient can have sepsis induced or some other infection induced renal shutdown is called. But complete shutdown and renal failure is very very common in NSAID induced nephropathy.
This patient, VBG was done, sir. It was showing a pH of 7.378 with a bicarb of 22.3, sir.
Okay.
And lactate was 0.9. And other things were within, like electrolytes and all were pretty normal range, sir. So we had done the other.
Which electrolytes all can occur? So many electrolytes.
Calcium, magnesium, and
Calcium, what happens?
Hypocalcemia will be there.
Hypercalcemia?
Hypercalcemia is a cause for.
Okay, so both can occur. Hypercalcemia induces pancreatitis. Pancreatitis induces hypo. So calcium is one important electrolyte. It's not an electrolyte. It's a It's not an electrolyte.
Mineral.
It's a mineral. Okay, so there is one of the most important mineral you have to check here.
Then magnesium also, hypomagnesemia can also.
Hypomagnesemia can be there.
Then secondary to this vomiting, he can have like hypokalemia, all those things, and he has like a reduced urine output, so we have to suspect hyperkalemia also. So electrolytes and like calcium, everything were within normal limits, like in our VBG.
Okay.
So we went with the other routine investigations. So the patient had a total count of 10,000 with a hemoglobin of
Hematocrit. That is very
hematocrit initial was at 33.1.
It's normal.
Almost like normal.
What is the importance of hematocrit in this patient?
Hemo concentration.
Hemo concentration. That's a very common finding what we see in patients.
And platelets were within normal limits, around 2 lakh. Then other lab investigations, patient's urea was 141 and creatinine was 5.87.
Okay.
Then this.
What you understood from that urea creatinine?
Sir, like mostly a pre-renal, this is like mixer around 20. It is. So it can be like some dehydration and something intrinsic also is there. So
Ultrasound?
Ultrasound, there was no features of CKD. Sir.
Okay.
CMD was main.
It's an acute renal failure. There is an element of pre-renal failure is there, but the patient, since it is very high, you have to always suspect some renal pathology.
Then patient LFTs, bilirubin was initially 13, sir, with a direct 7.83, and OTPTs were like 74 and 79.
So it's predominantly indirect hypertension. Indirect. More than 50% is indirect.
And his LDH was also 1,346, and peripheral smear was also showing like around 0.6% of schistocytes.
Okay.
Hemolysis
is there. Some amount of liver enzymes are
elevated. Then INR was 1.14.
What is the reason for hemolysis?
Pancreatitis, like infection.
Infection.
Can cause. Then it is a like inflammatory
Splenic.
It is an inflammatory condition, sir. So all these cytokines, all those things.
But LDH is very high. That means anything else you want to think. Somebody is having pancreatitis, obstructive lesions,
Malignancy.
lymphomas should be ruled out. Okay, but I am not telling it is lymphoma. It should be ruled out. There is hemolysis, but many infections can produce hemolysis, pancreatitis, some amount of hepatitis, jaundice. That is possible.
Then other things were like he had a ferritin of 1,800. Then amylase lipase. Amylase was 690 and lipase was 1,200, sir.
What is the cutoff point for diagnosis?
Like if more than 300,
more than threefold elevation, 3 times elevation.
If it is like around 240 to 300, more than that, it is we can take it as positive. So this was the admission values in our hospital, sir. So if we are taking the at the to know the severity, we can go for like Atlanta scoring, revised Atlanta scoring. So that is like not the initial presentation alone. We have to follow up the patient. If it and if the patient is this patient is having a multi-organ dysfunction, like AKI is also there. So if it is persisting like for the more than 48 hours, we have to take it as a severe pancreatitis. So this patient had persistent organ failure more than 48 hours. So it is a severe pancreatitis. So it basically, Atlanta classification basically divides it into three: mild, moderate and severe. Mild is like there is no organ dysfunction, no systemic complications, only some features of elevated amylase lipase and some symptoms. Even there won't be any local complication. Moderate will have the local complications and transient systemic involvement. That is, it will improve within 48 hours. But if the systemic involvement is persisting more than 48 hours, it is severe. So this patient, even like after 48 hours, he persisted to have renal dysfunction and all. So it's a severe pancreatitis. For this patient, since all this bilirubin everything was elevated, and they were the patient was initially admitted under gastromedicine. So from ER side, what we had done is that we had checked for his fluid status, and we had given him fluids. But after initial fluid resuscitation of around 1 liter, his IVC was full, sir. So we couldn't push him with more fluid, and he was mostly anuric. Okay. So we had to go with other restricted fluid. Other thing was analgesic. With the tramadol we initially gave, his pain had come down. So there was no need of further any analgesic thing. The other thing was all the electrolytes were normal, so we didn't have to interfere with that. So the patient requires the ICU admission. He got admitted under the gastromedicine department.
How you know that fluids will help the patient in pancreatitis?
Because of vomiting, the patient can have hypovolemia.
No, that's okay. Understood. I am asking, output. How do you know that patient improving with your fluid resuscitation?
If the patient has features like tachycardia, all those clinical signs improve. Perfusion
is the most important.
Urine output.
That you should remember. Any patient who is having hypovolemia, after giving fluid, if the urine output improves, then that is the best clinical marker of improvement in the patient. Okay, including renal failure. Okay, we don't know this renal failure is actually intrinsic renal cause or a pre-renal failure. If it is a pre-renal failure, when we give bolus doses, you can see urine output is coming out.
This patient would remain oliguria, sir. So he was later in ICU. He was initiated on dialysis for that, sir. So
what are the indications for dialysis in ER?
Refractory hyperkalemia, okay. Then pulmonary edema or anything secondary to renal shutdown, then uremia causing features like this pericarditis, all those things, end-organ dysfunction, like then toxicological causes like to remove toxins, dialysable toxins, persistent metabolic acidosis.
Here, why dialysis was initiated?
Sir, he persistent to be anuric, and there was no output, volume overload. So after around 24 to 36 hours, he was initiated. That time he was not having adequate output. Okay. Then other thing was an MRI was done from our hospital. Since the bilirubin everything was elevated, so with the plan of an associated MRCP, an MRI was done. So MRI was showing pancreatitis with some fluid collection with homogeneous enhancement and no necrosis and mild pleural effusion. If available, MRI can be done, but most commonly done entity is a CT, sir. So CT again, the CT picture help us in grading the severity of pancreatitis. Okay. So that we have a scoring, the CT severity index. That too has two parts. Initially it was a Balthazar score alone, but now we have a necrosis also added to that. So two scores are taken into consideration. So basically that too tells us about the complication. If it's a normal pancreas, if there is peripancreatic collections or there is features of necrosis, these things are noted in CT. This patient MRI was showing no necrosis, a pancreatitis with some collection. And other thing was, sir, the patient admitted to ICU on dialysis, pain management, and his blood cultures, urine cultures, everything was done, but they all are negative.
In a renal failure patient, how do you manage the pain?
Sir, opioids can be given, sir.
Opioids can be given, but what are the things you monitor when you are giving drugs?
One is prolonged time of action will be there. Like based, we have
So
to
you
look
cannot
for
give NSAIDs. It
NSAID.
is very important that once some doctors believe that once the kidneys are completely shut down, there is no recovery of renal functions. They still give NSAIDs, but according to standard guidelines, NSAIDs should not be given in whatever may be the renal failure, because in acute kidney injury it can aggravate. In chronic renal failure, it can produce water and salt retention. Okay, so both conditions NSAIDs we generally avoid. We don't give. Okay,
Then the metabolism of the drug we have to check. If it's like renal metabolism and excretion, it will be prolonged.
Okay.
So, like opioids.
Most of the opioids are through. So we
Opioids are safer in renal dysfunction, sir. Then
paracetamol can be given. Okay.
here, like we didn't give because like all the like though it is
Can be
mostly
given give paracetamol in this patient.
but it is mostly indirect only we can give.
In a
But
liver disease patient, how do you give paracetamol? When we give, what is the maximum dose can be given? What dose onwards it will become toxic?
in a day 2 gram can be given like for liver dysfunction patient.
The highest dose of paracetamol which can produce toxicity is 8 grams, nearly 8 grams. So we can give 2 to 4 grams. Even if the patient is having some liver injury like this, we can give paracetamol. But we generally avoid because sometimes even liver also will be involved after giving paracetamol. Okay.
Then other thing is like regarding antibiotic. So this patient has like ideally antibiotic is not indicated only if there are complications like necrosis or any collections and all, like like antibiotics is given. But this patient had a severe pancreatitis, so like he was started on antibiotics. So meropenem and all have better penetration, like so
Ideal drug is this one. Imipenem
celastatin.
Meropenem is a good drug, but in that group, imipenem celastatin has got a lot of studies. Okay, so they are better drugs according to standard guidelines.
This patient was started on sir meropenem.
Okay, what will be the dose?
Start dose we can give like sir 1 gram.
1 gram, then?
And other things like based on the creatinine clearance. So this patient will be like 500 BD or something. Creatinine clearance.
Okay,
will
according
be
to creatinine
more
clearance, you can modify the drug. Okay.
And
But this patient will be taken for dialysis. So those who are going for dialysis, this modification even may not be required because that will be removed by the dialysis. Okay, so that all depends on when you are placing the patient on dialysis. Okay.
This patient basically like what all complications we anticipate.
Now one more thing, whether you advise food for this patient, diet.
Sir,
Regarding that.
like the earlier thought was like to keep the patient NPO, but now it is like to start enteral feeding as tolerated by the patient as early as possible.
There is no pain for the patient after taking food. It is better to continue the diet, regular diet for this patient. What to be at avoid? Anything to be avoided?
This patient like in renal dysfunction also is there. The
Fatty food should be avoided for pancreatitis. Okay.
This
Renal
patient
failure?
proteins and all should be
Protein
like
should be
restricted.
avoided.
And this hyperkalemia causing foods also should be like restricted. This patient, this was the complications are AKI and some mild pleural effusion, and local complication was only peripancreatic collection. So like other complications are like local complications itself. There can be vascular pseudoaneurysms, pseudocyst formation can be there. Then sometimes bowel infarctions, thrombosis, all those things can be there. Then
Chemical peritonitis is one of the most important complications of pancreatitis. Then cyst and pseudocyst.
Then system wise also other systems as already told, like pulmonary there can be ARDS, pleural effusions, hypoxia. Then there can some patients the chance of going into DIC is there in severe sepsis. Renal already told AKI can be there. Then metabolic complications are like acidosis will be there, hyperglycemia can be there. Then this hypocalcemia, hypomagnesemia, all these things can be there.
You want to check the cholesterol?
Hypertriglyceridemia is a cause of pancreatitis. So that should also be like checked for, sir. So these are the basic things. And if it is a biliary pancreatitis, the patient may require interventions like ERCP for like
Any surgeon intervention should be there in pancreatitis, surgical
if
intervention.
it is a pseudosis formation and all, like causing rupture and all.
Abscess, pseudocyst, necrosis. I think we may have to call the surgeon very fast. Okay, otherwise it should be managed by
Vascular
GA.
involvement, like in aneurysms, like it can cause pseudoaneurysm sometimes, that rupture, and also there sometimes vascular intervention also should be.
Okay. Anything else, sir? Okay. What happened to the renal function of this patient afterwards?
Sir, actually, like patient, even after like 2 to 3 sessions of dialysis, his renal function persists to be like the same. No output and elevated urea creatinine, but other parameters had
Procalcitonin?
improved. It was 2.3, sir.
Okay, so he's not normally in a non-infectious pancreatitis like this. Renal involvement is very, very rare. Okay, if there is renal involvement like this, we have to find out a cause like NSAID-induced renal failure or an infection which produces pancreatitis hepatitis with renal failure, like hantavirus infection, or some other unknown or immune-mediated condition like SLE. Or in male patient, SLE is not very common, but even then you can investigate. Okay, somebody is having multi-system involvement, because pancreatitis as such renal involvement is occurring mainly due to pre-renal failure, not renal component is not very common. Okay, that's why. So we have to find out the reason. But most common thing is NSAID-induced renal failure. That will take some time. Okay. What are the features of NSAID-induced renal failure? Can you pick up clinically? Clinically means with some lab investigation. NGAL is it only indicates an acute AKI. It can increase before creatinine. Urine eosinophils. Okay, that is one preliminary test which may tell you that this is due to drug-induced kidney damage. Okay, it is very difficult to make a diagnosis only because of that. Okay. Is there anything else?
Nasogastric tube.
Sir, not ideally worn itself. The patient has persistent vomiting and not tolerating alone, like we can go for that. Otherwise, there is no need.
Pancreatitis, one of the complication, ileus. Okay, we have to know that one. No, one is the enteral feeding, we can change over to nasojejunal. Okay, good.
Thank you.